Hello, Professor Liao.
Hello.
Hi, thank you for coming. Okay, it's time. Okay, thank you for coming to join the very special topic by Professor Ko. Good morning and good evening for all our audience in ICC and Dr. Pang Win Cho. I am a plastic surgeon. However, today is a very special event for all our very honored and respected orthodontists. I am the moderator, and today's my co-moderator is the Dr. Prayer. So I would like to invite the Prayer to give us a special introduction for our very important and the key person tonight. Thank you. Prayer, please.
It's my honor to see you here again, our colleagues. And today we have a special orthodontist and a distinguished orthodontist from Singapore, Dr. Shen, to give us the lecture tonight. And we also have three panelists to join these sessions. The first panelist, Dr. Ellen Cole, the professor at Departments of Craniofacial Orthodontics and the director of Craniofacial Research Center, Chang Memorial Hospital, Taiwan, and chief editors of the TJO Taiwan Journals of Orthodontics. The second panelist, Dr. Rita Viwatana Tipa, a diplomat American and Thai boards of orthodontics, a clinical professor from Faculties of Dentistry, Departments of Orthodontics, Mahidol University, Thailand, and a well-known international speaker in orthodontic treatment, especially in the topics of cleft patients. And the third panelist, Dr. Johnny Liao, the president of Taiwan Associations of Orthodontists in 2013 and 2014, chairman Taiwan Boards of Orthodontics in 2015 and 2016, clinical instructor at Orthodontic Department, National Taiwan University Hospital, Taiwan. And this year we will have the Taiwan Associates of Orthodontists, or TAO conference in December this year, the 3rd and the 4th. And I would like to introduce this conference to all of you. Please capture the screen and go for the QR code for further information. And now is the early bird registration, so you can get a special discount for register this conference as well. And tonight, I'm so delighted to have all of you to join this session, and I would like to introduce Dr. Koo to the audience. Dr. Shen Koo acquired his dental degree at National Universities of Singapore in 2011. He completed an orthodontic training program at the Eastman Dental Institute, University College of London, and was awarded the membership in orthodontic from the Royal College of Surgeons of Edinburgh in 2016. And Dr. Koo is the orthodontist at the Cleft and Craniofacial Center, KK Women's and Children's Hospital, where is the largest specialized pediatric hospital in Singapore. Dr. Koo is a visiting specialist at the National Dental Center Singapore, and he had special interest in the novel techniques such as surgery-first approach, tooth auto-transplantation, and managing patients with cleft and craniofacial anomalies. And now he currently serves as the president of the Associations of Orthodontists in Singapore. Now it's time for the coolest cast tonight in the topics of auto-transplantation of developing premolar into the anterior maxilla. Welcome, Dr. Koo.
Hi, hello, hi everyone. Thank you very much. Okay, let me share my screen, please, if you don't mind. Okay, right. So thank you, Prayer, for the wonderful introduction, and it's so nice to see you here again. Last time we met was at the AOSC in Singapore, and a warm welcome to all our delegates from Taiwan, Singapore, Thailand, and all around the world. I'm most honored to be presenting today on the topic of auto-transplantation, and with the expert panelists of orthodontists and surgeons here. So I think we can all have a very exciting time. And after this lecture is done, I look forward to meeting everyone in Singapore, Taiwan, Thailand, and all around the world. So as shared earlier, I'm an orthodontist practicing at KK Women's and Children's Hospital in Singapore. and I'm in the department of the Cleft and Craniofacial Center. So we see a lot of patients with facial anomalies and cleft on a day-to-day basis. This is not my hospital. I wish it was my hospital, but it's actually the Marina Bay Sands, a popular tourist site in Singapore. And my training was in Singapore. My orthodontic master's program was in London, and I currently serve as the president of the Association of Orthodontists Singapore. I've been to Chang about 3 times now, and this was all pre-pandemic, so 2017, 18, and 19. And it's a wonderful place to learn new techniques, cutting-edge technologies from all the experts, orthodontists, plastic surgeons, and basically the multidisciplinary team. This is also the first time I'm on ICC presenting. The last one was when I was attending with Dr. Eric Lai, but it's my first time presenting, so I hope we can all have a great time together, sharing good knowledge. So this is an OPG of a 9-year-old patient, and this patient presented with an ectopic 2-1. This tooth didn't want to come out, so the essence of this was we did auto-transplantation of a lower left premolar, and we placed it into the position of the 2-1. 3 years later, this is what happened. The patient was already ready to take off the braces, and the patient had a nice replacement of the upper left central incisor. This is a fascinating technique which can help our children, especially those in need with trauma and accidents. So why auto-transplantation? Kids will be kids. Most of them think they are Superman. They don't know the dangers of what can happen. But even Superman will need to see the dentist, especially to fix their front tooth. So really, it's the parents' job to keep the kids safe and to prevent accidents from happening. But it is us dentists' job to think of how we can help them should the situation arise. So this is the outline of my lecture today. And also what I want to show you today is how to do simple auto-transplantation, especially for some of us who have not started any cases yet. We'll talk about how we can select good cases from the orthodontic perspective, and also what to look out for after transplantation in order to achieve successful healing. We can share some comments about the surgery itself and what is an easy surgery and what's a complex case. And definitely towards the end, some nice details on how we can position the tooth when transplanting to the anterior maxilla area, which is a very important area for aesthetics. So what is auto-transplantation? According to Schachowska, 2016 in a textbook, auto-transplantation involves a surgical movement of an available donor tooth into a recipient site in the same patient. And this is her additional part where it should be a part of a comprehensive orthodontic treatment plan. Yes, the transplantation is a surgical procedure, but we need the orthodontist input for the planning and also on how to move the teeth after the transplantation. It is a bit like orthodontic surgery, OGS. You could do the orthodontic surgery alone, but without the orthodontics, the patient is not complete with the malocclusion. So we need to work together as a team. A bit of background about this subject. Auto-transplantation was described as early as 1970s. So it is not something experimental. It is not something new age like Invisalign. This is Invisalign's grandfather. It has been described in systematic reviews and beautiful case reports, but I also like to share some experts in the field. So there's Dr. Jens Andresen from Denmark, who has since passed away. He's the pioneer of auto-transplantation. Dr. Ewa Czałkowska, who's from Poland, and she has so much experience, up to 20 plus years, and she does the most beautiful cases in auto-transplantation. So please listen to her lecture. She is an amazing lady. From Japan, this Dr. Sukiboshi, who is an expert in transplanting wisdom teeth into the space of first molars. So that's something that is fairly interesting, but we'll not cover that today because it's a bit too complicated. The current options for replacing missing incisors are implants, bridges, resin bridges, and also auto-transplantation. But of all these choices, not many would be a top choice for a growing child. You would never place an implant in children. Fixed bridges, if you had one tooth which had problems, you wouldn't shave all the adjacent teeth. And also, the survival rates compare fairly well with all the other modalities. So with auto-transplantation, I normally quote to my patients about a 90 to 95% success rate, given the right circumstance and in the right patient. Some clear advantages of auto-transplantation is that you're essentially giving the patient a natural solution to a missing tooth, because no other treatment option can provide a solution without placing a restoration, and that's why it's so special. We also get continued tooth eruption, and these teeth can move normally like any other teeth with orthodontic appliances. Yes, as orthodontists, we know how to do space closure, but you may not want to do space closure for every case, especially if it involves the upper incisors. Sometimes you may have small lateral incisors or very large and bulbous canines, which are yellow. So that may not be an option. I think the best time to do auto-transplantation is between 9 to 12 years old, if you're referring to choosing developing premolars, because any later than that, the apices of these teeth will have fused together, have closed up, and then the success rate of pulpal revascularization drops significantly. It's not to say that you can't do auto-transplantation after 12 years old. You can, but you will require an additional step of root canal treatment, which is normally done about 2 weeks after the transplantation surgery. And also the survival rate does drop a little by about 2 or 3%. The biggest hurdle to doing this treatment is that it is a multidisciplinary treatment, which means that we need to gather people with a similar mindset and experiences in order to achieve a good outcome. We cannot do this alone. So as a dentist, what do? We're basically not taught auto-transplantation or even exposed to this idea in the undergraduate levels. So the next thing is we might start to think and wonder, is this something safe? Is it something we can worry about? Is this even herodontics? Is this something that we should be doing on our patients? And a lot of us, because we don't know these things, we try to depend on, we look around and we see our friends doing it, our colleagues, surgeons, orthodontists doing it. And in Singapore, there are 2 or 3 main hospitals which are quite good at auto-transplantation. So fortunately, the surgeons already have the forceps, and also I'm your colleague. So after this lecture, I'm sure most of you can already start doing 1 or 2 cases. The feedback from patients whenever the child comes in with a traumatized tooth is that none of the dentists have a good solution for the child's problems. And this is because the parents will come into the office with the child and they expect something to be done. They come in because they trust the doctor's advice. So if your advice is to give a denture to the patient, then the patient will trust you. They will go home with the denture and wear this until 18 years old, which is okay, but we could give something better. So we should not ignore the parents' and patients' wishes that something more permanent needs to be done, as parents often want something done sooner rather than later. And also we have to consider the potential side effects of having a missing front tooth, especially in a growing child, in a very unforgiving classroom environment. So this paper by Bjorn Zackerson in 2004 talked about auto-transplantation in the maxillary anterior teeth, quite similar to my topic today. This was my inspiration. And he roughly describes the best cases to start. Firstly, class 2 patients, low angle with missing lower second premolars. So you can imagine to take out the upper premolar and place it and transplant into the space of the lower missing 5. The other easy cases we'll talk about is patients with evals or missing central incisors. So this essentially is what we'll be sharing a bit more. Now let's take the transplantation from this perspective. This patient came in with a 1-1, which had poor prognosis and a severely resorbing root. So the first thing we think about is when we want to replace a failing 1-1, which tooth do we choose? Of course, we wouldn't choose a molar to put into the central incisor, so we choose premolars. And when thinking of auto-transplantation, we rarely ever go for the first premolars because the first premolars, 1-4 and 2-4, have 2 roots. And we try putting 2 roots into the socket space of 1 tooth is very difficult. So we try not to do the 1-4 and 2-4. In the case of this patient, because the 1-1 was the one that was injured, we try to avoid taking teeth out from the same quadrant. Instead, we take out teeth from the other quadrants between the upper 5s, the lower 4s, and lower 5s. The ultimate decision lies on the orthodontist because they need to think and plan about the eruption status of the premolars, how much root development has happened, and also whether the teeth extracted makes sense in terms of the overall malocclusion. So the ideal donor tooth is really the premolars, if you shared earlier, with also incomplete root formation. The open apex in a growing child means there's more likelihood of pulpal revascularization after transplantation, and we can then avoid root canal treatment. So according to the Maurice classification in 1963, we are really aiming for stages 3 to 5 to get the best outcome. Because anything beyond stage 5, stage 6 and 7, the apex will start to close, and then you might plan, maybe we need some root canal treatment. Anything too early, it may be a bit risky because the root has barely even formed. So I think about half to 2/3 would be just nice in terms of the root development. Also, when choosing the teeth, we normally choose premolars which are single-rooted and partially erupted. A few more considerations orthodontically. We're really thinking about the right case. So we choose patients, and for auto-transplantation, we would generally prefer some crowding because in order to extract teeth, we need some crowding. The other thing is in patients with class 2 malocclusions, we would normally choose the upper premolar to extract, so it won't make the overjet worse. And similarly, in class 3 patients, we'll go for lower premolar extractions so that we can help to compensate and bring a positive overjet. In patients with a class 1 malocclusion, the sky's the limit. You can choose between the upper or lower premolars, which is quite similar to extractions for orthodontic treatment. If you can remember this, then choosing the right tooth is not too difficult. So always start with an easy transplantation case. Why? Because if you do your first case and you fail the first time, I promise you will never ever do auto-transplantation again. So don't make it difficult for yourself. Choose an easy case. Dr. Sukiboshi is an expert at wisdom teeth and molar transplantation. So he has all the experience he needs. Both myself and you may not be so good at the wisdom teeth because if you were to remove the wisdom teeth atraumatically, that'd be great. But if you can't, then the likelihood of failure might be higher. So stick to the developing premolars and you wouldn't go wrong. So the person really deciding on the final treatment plan is between the orthodontist and the oral surgeon. This is my surgeon, Dr. Chan Boon-Hui, and I, and he has a special technique of removing premolars atraumatically. And through him, I've also learned that not all oral surgeons are using hammers and strong muscles during the surgeries. So you need to find a surgeon they can work well with, and then naturally your good results will follow. Auto-transplantation is a orthodontic-driven plan. And what I'm going to say now is going to make a lot of surgeons happy, but it is the truth that the surgeon has the final decision because I give him my plan, but ultimately he decides whether it's possible to use that tooth based on the experience and location of the premolar. So this first patient is an 11-year-old girl, and she came into the children's emergency with a crown root fracture of the 1-1. She was seen by the pediatric dentist who helped to put the splint and decoronate the tooth. And also after testing, they realized that, well, the 1-2 and both the 2-1 were non-vital. So we started root canal treatment immediately to help these two teeth. After root canal treatment, the plan was to place a simple partial denture in the space of 1-1 and to maintain the bone until 18 years old. But as things have it, there was active root resorption, replacement resorption happening on the mesial and distal surfaces of the 1-2 and the 2-1. So we went back to the patient and told her about the information, and then we all came together and we had to start to plan. So now she has 3 incisors, which had poor prognosis and which will be needed to be extracted. In this case, we talked about placing a denture with maybe 3 pontics at the incisors, but the patient was not keen on that. So we went to the CBCT, and there were 2 lower developing premolars with a nice open apex, about the stage 4. So we decided to take the 3-5 and the 4-5 and to place it in the space of the 1-2 and the 2-1. We went on with the auto-transplantation surgery, and we removed the 2 ankylosed teeth and also the buried root. After the flap was raised, more space was expanded on the 1-2 socket in order to accommodate the premolar root, which was a bit bigger than the lateral incisor. In this case, the interdental bony septum fractured, but don't be afraid if you lose the septum because we don't need it, and it's obviously different when you're placing implants. That's absolutely necessary, but in auto-transplantation, it is still okay. We placed a 3-5 and a 4-5 and a very flexible wire splint, and the patient was out of occlusion and left to heal. So after placing these transplanted teeth in a new position, we need to start watching and monitoring these teeth. We can see the transplanted teeth in their new location, and we reviewed them every 2 weeks, months, 6 months, and subsequently yearly. In this case, we had successful healing, and both teeth were vital, so no root canal treatment was needed. We then monitored her regularly to observe for continued root development and also for pulp canal obliteration. In this case, the root of the upper left premolar was placed quite near the apex of the 2-2. And this was our small error, but we're getting better, and we're getting better with more precise positioning. And also we'll show you later some methods on how we can improve the placement of the premolars. So the teeth which have been affected by trauma, they normally show very transient readings. In order to really monitor them, we should do the vitality testing, but don't take this at face value because sometimes they can be negative during the healing phase. But I think what's more important is really the whether there's any absence of the PA lesion, so that we can detect any resorption or PA lesions in the radiographs. And if there is, we need to revise the treatment plan. In the same patient, after transplantation, we removed the splint after 2 weeks and we left the patient to heal. We then placed a composite filling on both the 3-5 and the 4-5, and then we waited 6 months before doing any orthodontic treatment. Here's the patient after 9 months of orthodontic treatment, and this is where we're at. So remember how I said just now that the 2-1 was, well, the 2-1 or the transplanted 2-1 was placed quite close to the apex of the 2-2. So we placed the bracket positioning of the 2-1 at an angle in order to help to upright the 2-1. The beauty of this is that the teeth can move normally with orthodontic appliances. We just need to give it a bit more time to enjoy its new home. So in the upper arch, we place an 014 nickel titanium wire for simple alignment and leveling, and in the lower arch, space closure to help reduce the spaces. Obviously, in this picture, we developed an anterior open bite, so we had to close this later on. Here, at 16 months, we proceeded to extract the 2-4 to help with the upper centerline correction. We only took out the 2-4 after we were sure that the 2-1 and the 1-1 were moving normally and they were showing signs of vitality. And this is important because if you took out the tooth at the start of treatment, you may risk having, like I said earlier, 2 units. You may be short of 2 units on the same quadrant if the planning was not proper. We also added some asymmetric cross elastics to help with the centerline correction and also to focus on closing the anterior open bite. So at the end of 2 years and 2 months, we debanded the patient, and it was a bit challenging to achieve a good result because of the asymmetric orthodontic extractions and canine substitution. We had teeth 1, 3, 4, 5 on the right side, and on the left side was 3, 5 and 2, 2. It was not a perfect result, but the patient was happy with it. And we had composite veneers placed. In the future, she could consider some porcelain veneers to help correct the zenith of the 2-1, which I think have been positioned a bit more distally to the midpoint of the tooth. So this is the same patient about 3 years later with roots parallel and looking beautiful with a long-lasting natural smile. This is even more important because we managed to avoid the use of dentures or implants. Now let's take a look at some important orthodontic considerations before we start moving any transplanted teeth. The first thing we really like to think about as orthodontists is which brackets do we use to place on the transplants. And the answer is quite simple. Imagine this: after transplantation and the composite veneers are placed on, the teeth look like central incisors. So in this case, we choose the central incisor brackets because this bracket fits the tooth surface best. If you're thinking of moving teeth before the composite buildup and it's a bit curved, then you could naturally put some premolar brackets to help with the adaptation of the bracket onto the crown. Looking at some research from TMDU, the authors looked at 100 auto-transplanted teeth with complete root formation, and this included premolars and molars. So what they did was they started moving the teeth after just 1 to 2 months after surgery. Of the 100 teeth, 7 teeth failed and were removed, 15 were ankylosed, and 10 of them had root resorption. This gave a final success rate of about 71%. So what do we do here? I think when approaching this, we try to apply a bit of common sense. If the patient suffered trauma of the central incisor, would you really start moving after 1 month? I mean, you could, but I wouldn't because, it takes time to heal. So this book by Andresen outlines the guidelines that for safety, wait about 3 to 6 months. 3 to 6 months because we need to wait for PDL reattachment, continuous laminar duration formation, and also to make sure that the root development is complete before moving the teeth. For patients with unerupted teeth, plus 6 months to that, so 9 to 12 months after surgery, you can start moving the teeth. Now let's look at a few surgical considerations in order to achieve a great result. When doing auto-transplantation, we have to be very careful, we have to be gentle. So when we remove the teeth, you might damage the root surface, so always atraumatic surgery. Now, when taking the teeth out, we have to be super, super careful, and we can't do extractions like this. We can't pull the teeth out like this because when you do that, that's where you get ankylosis, resorption, due to the damage to the cementum and also the Hertwig's epithelial root sheath. The average surgery doesn't take very long. From the time of removal of the transplanted tooth into the socket, it should be less than 30 seconds because any longer, you make it even worse for the final outcome of the treatment. So the whole idea is that you don't take the tooth out, place it in, take it out, place it in, take it out a few times because that's what the planning is for, so you can avoid this unnecessary try in and try out. Then we ask ourselves, do we normally go for suture or wire splint stabilization? And Andresen believes that using sutures allows for more physiological movement of the transplanted tooth, which will promote better healing, and that using hard wire splints can predispose this teeth to pulp necrosis and premature ankylosis of the tooth. And I agree. So to meet in the middle, we opt for a flexible wire splint. And as Dr. Johnny Liao best puts it, we are orthodontists, we love wires. Personally, I prefer the erupted tooth because it's a bit more visible and there's easier access for the surgeon. So naturally, once you can see the tooth, there's less chance for damaging the root cementum. Many other centers prefer the unerupted tooth. And I think it's a great idea because by taking the unerupted tooth, you're able to induce more bone formation. So if in the case of the first patient where there was missing a bone due to the fracture, then placing an unerupted premolar would encourage more bony formation. However, I don't like doing unerupted teeth unless absolutely necessary. I mean, it's okay, but I'd rather not, because if you do it wrongly, the chances of damaging the tooth will be higher. So in this case, we took a unerupted tooth and we actually made a mistake because when transplanting this tooth, we may have caused some unwanted damage to the tooth. So at 2 weeks, when we placed the transplanted tooth into the space of the 2-2, this is what it looked like. And about a year later, what happened was that the apex has started to close, but the root length has not increased at all. And while this is considered a survival of the tooth, personally, I don't think it's successful at all. So, like I said, if you start off on the wrong foot and you have a bad outcome, you may not want to do this again. So choose an easy case, choose something, a premolar which is erupted, then the success may be a bit more predictable for you. Don't be like me. This patient, he's Elton, and he had quite an interesting story. He had an accident at home where he fell in the bathroom and his front central incisor was avulsed and it fell into the toilet bowl. So after grabbing the incisor from the toilet bowl, they brought it back to the children's emergency in the hospital, and the pediatric dentist helped to do the root canal treatment. During the review stage, we realized that the 1-1, despite the root canal treatment, suffered some inflammatory root resorption near the mesial apex of the tooth. So the decision was made to remove the 1-1 because it was not viable. And once we take out teeth, we have to think, okay, how do we replace them? And in this case, we use auto-transplantation. In the same patient, this is a CPCT, and you can see around the 1-1 and 2-1, there's barely any labral bone. So using the CPCT is a very useful tool to help us in the planning for auto-transplantation. We don't take CPCT for routine cases, but for cases with orthodontic surgery, impacted teeth, cleft, and in this case, auto-transplantation. These are very good examples of when it's indicated. So we can use the CPCT to study the two locations, the ideal recipient site and also the donor tooth, which one will be selected for the transplantation. In this case, when we took out the 1-1, there was no cortical bone labially at all. So we decided to use the 4-5, which had a nice open apex. So we felt that it was the best tooth to be selected for the replacement. So everything from start to finish is planned on a cone beam CT. And this 3D model was segmented by myself and printed out with a 3D printer. Similarly, you can virtually extract the incisors in the upper arch to reveal the sockets. And if you need, you can even print out the entire maxilla without the teeth so that you have the space and to trying the tooth before you see the patient. So the patient went for the surgery. The 1-1, you can see there's a space there. After the socket creation, we managed to try in the tooth with the 3D replica. And once the surgeon was happy with the space, we proceeded to place the actual tooth into the location. And then subsequently, we used a flexible wire splint to help secure the tooth in place. 1 month after the surgery, the tooth is in a good position, and the composite buildup was done to mimic the 2-1. So the treatment was complete, and now we wait for the successful healing before we start orthodontic treatment. 6 months. Looking at the research and survival of transplanted teeth, in this study, the mean observation time was 26.4 years, and the authors yielded a survival rate of these teeth at 90%. In this other landmark study examining 370 premolars, there was a survival rate of 95% for premolars with incomplete roots. Another finding the authors had was that the complete root development was significantly related to the risk of pulp necrosis. So this tells us that we should choose premolars with open apices in order to get the best survival rates. Now, aesthetics in the anterior maxilla is something that we all know about, but we don't talk about enough, especially when managing auto-transplanted teeth. So let's look at a few factors we need to discuss and to focus on to make our cases look more aesthetic. So these are 3 cases where auto-transplantation was done, and I found them on online journals. When doing auto-transplantation, the most important thing is it doesn't matter if the transplanted tooth is a success. In these 3 patients, it was successful, but was the patient happy? Probably not, because in order to make it a true success, it has to look good. The only thing patients care about is whether the teeth look good, the aesthetics. So the attention to detail is very important when dealing with the anterior maxilla. It's a bit like doing finishing in your orthodontic cases. Spend a bit more time, make sure the gingival levels are good, make sure the bite is clear, there's no heavy occlusion on the teeth, and naturally, you will be rewarded at the end with a very happy patient. So this is what we want from that to here. So a study by Dr. Shkoskara analyzed the aesthetic outcomes of auto-transplanted premolars, and what did they find? She found that while most of them were satisfied, 18% were not satisfied due to the aesthetics, mostly the color and the gingival width of the transplanted tooth. And this was before orthodontic treatment was done. So after this study, they realized that, well, in order to improve the overall outcomes and success of your treatment, definitely do consider some orthodontic treatment to improve the positions. And I think the way we can apply this in our practice is that if you do consent with your patient and treatment planning, we have to inform them that, look, we can do the transplantation for you, but you must promise that we also do the orthodontic work for you. Because if not, and they can't commit to the orthodontic treatment, then maybe dentures or implants will be a better option for them. So a lot of us finish our orthodontic cases in teenage years, since most of our patients are quite young. And this paper by Dr. Vincent Kokic went on to study just how many patients were able to fit implants after the spacelets were open when he compared them at time of implant placement. So from time of deband to implant placement could be about 6 years, 7 years, and up to 11% of these patients experience relapse significant enough to prevent implant placement, which means that future orthodontic treatment needed to be done, and he even suggested that placing a resin bonded bridge permanently can help to prevent this relapse from happening. The reason why this is so difficult is because we are always dependent on the patient's compliance and the maintenance of the prosthesis. So failure to do so will make it more unpredictable, which is why implants and prosthesis may not be so good all the time. Again, with dental implants, if done at the right time, with the right technique, I'm sure you can get a good result, but don't just believe all that you've heard your colleagues say. Look at the results as well. Consider, will the patient receive implants with gray margins? Infraocclusion. I used to think that implants could be done at 18 years old, but having seen some results myself, I think if you push it back to about 20 plus, it'll be safer, which means the patients may be wearing the denture or retainers for close to like 8 or 10 years. Which is why if you don't want to think about the compliance or maintenance, do consider space closure, because space closure is better. It saves them money and they get to keep the natural dentition. Also, in cases where there are large edentulous spaces with lack of interdental bone, it may not be feasible to place implants because the final result may not be aesthetic. In this patient, not my case, they placed 2 premolars to help to induce some bone formation, which I think will give the patient a very good result at the end of the day. And I have to present this case to you. It's quite interesting. This boy was an 11-year-old boy who came in with a similar presentation, avulsion of the 1-1 and subluxation to the 1-2 and the 2-1. After the accident, both 1-2 and 2-1 were non-vital and they were ankylosed. So the interim treatment was to place a partial denture in the space of 1-1 to help him through. From the side profile, the patient presented with a class 2 convex facial profile with an overjet of 11 millimeters up to the 2-1. So not only do we have to think about the auto-transplantation, but also we have to manage the patient in terms of his overall orthodontic class 2 malocclusion. This is the OPG of the patient, and looking at the apices of the lower premolars, we started to think, okay, maybe this might be a good time to consider auto-transplantation because on the lower premolars, the teeth were single-rooted and also they had open apices. However, based on his dental development, they were starting to narrow a little bit, which means that we didn't have much time to decide the treatment plan, because if it started to close, then auto-transplantation may not be the best option for him. Here's a PA of the patient. So the 1-2 after root canal treatment had resorption on the mesial and distal surfaces, and likewise on the 2-1, despite a good root canal treatment, it was not viable. So we had to plan to remove not just the 1-1, but the 1-2 and the 2-1, 3 teeth altogether. Here's a cone beam CT of the same patient, and we were analyzing and picking the best tooth. Because he was slightly more developed, the root apices are starting to close. So instead of choosing a stage 3 or 4, this was more stage 5, just at the upper limit of stage 5. And then we think about which was the best area to put the transplanted tooth in. And in this case, we said the 1-2 was a bit better because you can see some nice cortication on the labial surface of the tooth. On the 2-1, it was a tooth which was ankylosed, it was proclined, and there was barely any labial bone on the surface. So we told the patient that the root apex was about to close and that any later we not be able to have the same option for auto-transplantation. And luckily, the patient was quite kind and understanding. So 2 weeks later, they were booked in for the surgery and we went ahead. So this was the actual surgery. Patient was asleep. We took out the 1-2. We removed the 4-5 atraumatically, and we placed the 4-5 into the space of the 1-2 socket. Once that was done and occlusion checked, the surgeon placed a nice flexible wire splint in order to stabilize the tooth. If you remember, the patient had 11 millimeters of overjet. So although the patient looked like he was biting on this tooth, he wasn't, because he managed to clear the occlusion. And in the last picture, the pediatric dentist did a very nice composite buildup onto the transplanted tooth. So we said, okay, we'll see you back in 6 months' time after the healing. We can start orthodontic treatment. But unfortunately, the patient, he had exams and he had schoolwork, so he could only come back slightly later at 9 months. The treatment plan for him was very simple. We took out the 2 teeth which were ankylosed, the 1-2 and the 2-1. We took out the 4-5 in order to auto-transplant 4-5 into 1-2, and also 3-4 for centerline correction. After the surgery, we planned for orthodontic space closure, and after the braces, composite buildup. So this is where we're at after 2 months of orthodontic treatment. The 2-1 was ankylosed, so we kept it there in order to maintain aesthetics. Looking at the gingival margins, it was not pleasant because they were all in the wrong places and not harmonized. Comparing the center lines as well, both the upper and lower dental center line was shifted to the right of his facial midline. So all these things needed to be corrected. Once we were sure that the transplanted tooth was moving, we excised the 2-1 and we decoronated the crown and maintained the pontic in the space of the 2-1. Every visit, I would reduce the mesial-distal width to make it a bit more narrow. And also, I'll help to grind the palatal cusp of the newly transplanted tooth a little bit more. At 17 months, we can start to see things are taking shape now. We have gotten the gingival margins a bit better, and we're idealizing spaces based on what my prosthodontist wanted in order to achieve a good buildup for both the lateral and the 4-5. Looking at the occlusal view from the bottom, we can see that the transplanted tooth has very nicely cleared the occlusion, and this was due to the grinding, the selective grinding on the 4-5 palatal cusp. The prosthodontist took over and then did a mold of the patient's bite and started to do a wax up. And from the proportions, she was able to transfer the gingival heights and, more importantly, the incisor edges from the mold into the patient's mouth. So at 22 months, we're in class 1, and the prosthodontist has placed all the composite fillings. We also did some enamel modification on the palatal cusp of the canines to help remove the interferences, and also on the distal surface of the canines so that they can look more like lateral incisors instead of canines. So finally, just checking again, the gingival margins were much more improved compared to the start of treatment, and we had quite an unusual, not asymmetric smile at the end because it was 1-3, 4-5, 2-2 in the place of the central incisor, and 2-3. So here's the final result of the patient with fairly good pink symmetry, harmonious gingival margins, and nice aesthetics. But more importantly, I think this was the take-home message, is that we managed to give the patient a good natural dentition with no implants, no bridges, just good old orthodontics and retainers in order to maintain the bite long term. In the same patient, here we have a 3-year follow-up post-auto-transplantation, and we can see full root development and also near complete pulpal obliteration. There's also no PA lesion, and the tooth was still testing vital on sensibility testing. The OPG and the LET-CEF of the patient. And also the continuous radiographic monitoring at the 4-5, where you can slowly see there's continued root development, and quite distinctly with pulp canal obliteration, which is a very common sign of a vital tooth in transplantation. So I think all in all, whatever we shared today, I still believe that auto-transplantation is fascinating, and it's made it so much easier to treat these patients, young patients, without the need of any prosthesis. So we can not only save money from the implants, but we can save the environment by using auto-transplantation of the premolars. And we as orthodontists, we work as a coordinator, so we always end up here on this successful site, not here without the lack of planning. And I think I'd just like to end off by saying it's so important to work with a good team, because we must find a team that enjoys treating young children, enjoys doing new things, and trying new techniques just to improve ourselves, which makes the overall experience more and more enjoyable. So I think they shared this earlier, but I'll see most of you at the TAO in December this year. Looking forward to the exciting event, and thank you all to the organizers for the invitation. And lastly, I'd like to thank everyone for your unwavering attention, and thank you all very much.
Okay, thank you, Professor Koo, and the prayer, please.
Thank you, Dr. Koo, again for your great presentation. Yeah, I have learned a lot from your session. And the first one, and we will go for the panel discussion. The first one, I would like to invite Dr. Johnny Liao for the panel discussion.
Okay, thank you, Dr. Koo. Thank you so much for your wonderful presentation. It was amazing. And actually, I do some auto-transplantation, but I barely have experience on the developing premolar auto-transplantation in the maxillary anterior part, because most of my patients are adult patients. It's around 80%. So my first auto-transplantation case actually involved a premolar auto-transplantation and another one a molar auto-transplantation. And the big difference would be pre-existing socket. I think for auto-transplantation, the prognosis would be much better with the pre-existing socket because there are PDL cells from socket and also from the donor tooth. So it is the major difference. And for me, I especially look at the patient's age, because many of my patients, they are not adolescent patients, and even more than average age, maybe more than 40. Because in Dr. Tsukibo's study, he mentioned about the higher success rate in younger patient. Of course, we all know about this, but you cannot choose the patient. So I do a lot of comprehensive, I mean the full mouth rehabilitation, and many of them, they are older. So the prognosis is much poorer in these adult patients. But one thing I do not know very well is about the vitality of the obliterated pop canal. Is it positive or negative?
Yes, okay, great. Thank you, Dr. Liao, for your questions and for sharing your opinions as well. Actually, I heard your lecture at the AAO, I think it was about 5 or 6 years ago. That was very exciting. And you presented on auto-transplantation with other techniques, with TADs, TADs, and also with implants and so many other interesting things. And I think in that presentation, you even talked about moving teeth as young as 17 days. That was how fast you moved it. So that was incredible.
That is because I do not use the transplant as the anchorage. I just leave it in the soft arch wall, and I use the mini implant to be the anchorage to move the front teeth. That is why I can start the tooth movement earlier, because actually they are passive. They are passive components.
Yes, okay. I know, I agree with you. Yes. We don't want to put too much forces on the anterior teeth. So your question about the pulp canal obliteration actually is a very common finding for patients with developing premolars. And as you can see, not just in auto-transplantation, but in young patients where they had tooth avulsion or suffered some trauma to the teeth, naturally the body's mechanisms is to put some reparative dentine, and these teeth, they do actually have positive testings to the vitality EPT. It's the only challenge and difficulty is that if one day the tooth does develop a periapical lesion, and they become non-vital, then it is the endodontist's worst nightmare to treat because the pulp canal has shrunken so much, and obturating it and finding the canals would be a nightmare. So don't refer it to your good endodontist friend, but not to the other ones. Yes, yes.
Okay, thank you. And I think the do you have experience in I mean try the auto-transplantation by drilling the fresh socket and use the implant kits to prepare the recipient site?
Yes. Yep. So
Yes.
actually, in the last patient, the boy, the class 2 boy, we chose to use a transplanted 4-5 into the socket space of the 1-2. But because from the measurements, the tooth was a bit too big for the 1-2 socket, the lateral incisor socket, the surgeon had to prepare the space by using implant kit. You're right. And while doing that, you expand the socket, you might also unwantedly destroy the PDL cells, which will help for the reattachment. So we try to be careful. We try also to choose teeth which can fit nicely with minimal preparation. And exactly, you're right, because the moment you compare transplanting teeth into fresh sockets versus artificial sockets, it can go down by as much as 30 to 40%, I believe.
Yes. Okay. Thank you.
Okay.
And may I ask one more question? I like to ask about how do you decide to rotate the premolar or not when you try to move the premolar to the incisor area?
Okay, so the obviously we look at the shape and the morphology of the donor tooth first, and naturally I personally like choosing the lower second premolar, so the lower 5s, which are quite conical, quite round by nature. So whether you turn it 90 degrees or straight up, it's still round. You understand? Yes. But I understand also that many articles, they talk about rotating the premolars 90 degrees in order to get a slightly wider profile. But I believe that Dr. Eva Shokowska, she mentioned in the transplantation Congress about 3 years ago that there's no benefit of using the 90-degree method, because once you turn it 90 degrees, it becomes a bit too wide. So if you choose the normal way, straight, it's a bit narrow. But if you turn it too wide, turn it 90 degrees, it becomes the other problem, too wide. So maybe some prosthodontists would comment, but I feel that it's easier to restore when it's a bit narrow than when it's a bit too big.
Okay.
Yeah.
Thank you.
Okay.
Thank you very much for sharing your experience. And these cases are wonderful. Thank you.
Thank you. Thank you very much.
And the next panelist, I would like to invite Dr. Nita to give us our comment on the panel discussion.
Thank you, Dr. Pear. First of all, I would like to congratulate Dr. Gu for your superb presentation. It is such a wonderful presentation, very informative and interesting. I do have a question regarding the replica of the tooth which you prepared. Could you elaborate more? How did you prepare it? Using which software?
Sure. I think a lot of people use more sophisticated software. So if you have an intraoral scanner, like the 3Shape Trios, you can use the inbuilt software as well to segment it yourself. That's if you have a lot of time and if you have the experience. For myself, I wanted the fastest way. So I went on Google. I went to this website called RELU. It's a European site, RELU. And it's very simple. You upload the entire CBCT, so 200 megabytes plus of upload. And in 1 minute after the upload is completed, they'll help you segment automatically. Everything is automatic. So you can select which tooth you want, and they can even remove the models, remove the teeth virtually. Because I don't own this software, you actually have to pay about I think $8 US. But I thought for this case, $8 is very cheap for a more predictability and better sleep at night. So it's all automatic. I'm not an expert. I'm just figuring things out by myself as well, but this was the software I use. I can send it to you later.
Thank you. I would greatly appreciate if you could pass on the link. Thank you.
And last, I would like to invite Dr. Ellen Cole to give us the comment on this topic.
Thank you, Dr. Pryor, and congratulations to Dr. Koo for your really nice presentations. And I really like you that you use 3D kind of simulation to do this kind of auto-transplantation. And we know that if the cases have incisor coming out, usually they are come with dental protrusions, or some of them they are crowded, so they have some of lower premolar can be extracted to replace the upper teeth. So we expect that most of the patients need orthodontic treatment afterwards. And for the cases with procline upper incisor, if you are you got a replica to prepare the socket and put the tooth into the position, do you think about that you will change the angulation when you do the transplantations? And so you can kind of avoid too much orthodontic force on the patient, especially they have procline upper incisors.
Yeah, actually, this was something that we really considered a lot from our first few cases, because as we were trying to figure the right method and the right technique, what we really felt was by placing the teeth into the original socket, as Dr. Johnny Liao shared earlier, we're able to preserve as much of the PDL structures, and that will help for the reattachment and for the healing, so that the orthodontic treatment will be easier. Now, if we wanted to change the angulation of the incisors, it is possible, but I think we must also wonder whether we will need to use an implant drill to create a bigger space. And then once we create a bit more space with the implant drill, then we are in the same territory as having artificial versus a fresh socket discussion. And naturally, we'll try to avoid that because the survival rates may be a bit lower for the healing. The other thing I really experienced myself was that after the auto-transplantation was done, my pediatric dentist did such a good job in making the crown look so nice. So some of the patients didn't want to do orthodontic treatment after that. And also, because it looks so straight and so nice, I put my bracket on the right way, but actually, you're right, the tooth root was placed in another direction. So it confused me a little bit. So I'll say always put the tooth into the most comfortable position and try to avoid surgical preparation and expansion of the socket if possible. And when the patient comes back, before you put the braces on, be careful. Don't be fooled by how beautiful the tooth looks. If you need to trim down the labial surface and make it flatter to see the proper root top, then we need to do so. Don't just put the tooth bracket on, because if you put a nine-tie wire, sometimes the entire root might come forward out of the bone. So avoid that, be careful.
Yes, yes. And we a lot of panelists, or you have treated the cleft lip and palate a lot, and we know that most of the cleft, they don't have lateral incisor, half of the cases. So we did a lot of tooth substitution, canine substitution, or even lateral substitute to central incisor. So if there is just one teeth avulse, sometimes we just move the lateral to substitute the central incisor. In your experience, which outcome will be better or predictable in aesthetic, in the function, and also in the patient's burden of care?
Yes. I think it's a great question, and it's always that there's two sides to everything. Personally, I'm my comments will make all the dentists quite angry with me because I don't like to put implants for my patients. I don't like to have them wear bridges or dentures or anything. I always choose the space closure and canine substitution rather than space opening. And the entire idea here is that by being able to close the space so well, and we're not just talking about closing it like this and finish. That's not right. We need to close the spaces, make sure that the occlusion is not interfering. And also, like we shared earlier, we have nice gingival margins so that it's aesthetically pleasing. And when talking about achieving class 1 canine relationship or group function, there's actually no difference at all, because by closing spaces, we no longer have canine function, but it's a group function on the lateral excursions. And it's a comfortable position with no additional TMD problems. And also the overall aesthetic result is, in my case, I feel in my hands, it's a bit more predictable. Yeah. So it's a choice between yourself and what the patient wants, but I would normally lean on the side of space closure if the patient is okay with that.
Yeah. Congratulations. You have a nice team to work with.
Yes. I think some of them are here listening too as well. So I'm very happy for their support. Thank you.
Yeah, thank you.
Thank you, Dr. Koh.
Thank you.
And next, I would like to invite Dr. Low to join us the panel discussion. Dr. Low.
Yes, hi, Dr. Koh. Very nice to hear your talk, and I'm quite impressed your result. Actually, I would like to continue the issue from the Dr. Koh that we are treating patients with cranial and palate, and very common that they have so-called upper jaw hypoplastic and lower jaw more protruding, class 3, and it seems that, and also we have a patient that has missing lateral incisor. So it's really, from listening to your talk, seems that it's also one of the good options that we can apply in the future, that we can move some premolar to the upper, the maxillary lateral incisor. Do you have any experience of doing a patient with CREP, and what is your comment on if we wish to start this kind of management?
Okay, great. So thank you very much, Dr. Low. I feel that we are personally working in the same hospitals, and we are seeing the same kind of patients with cleft and missing incisor. So that's quite useful. Your question about placing transplanted teeth into the cleft site, I think it's not something that's new either. It's been done before. There's a paper by Hamamoto in 1998, Japanese dentist, and he talked about 2 different cases where he placed the transplanted tooth into the cleft site. And personally, I have done a few transplanted teeth in cleft patients, but never into the cleft site. So if the cleft patient has a missing upper right second premolar or a missing lower right second premolar, we do the transplantation into the areas, but not into the cleft site. And I think fundamentally, when treating cleft, you have to be quite aware of the structures. So if, for example, after the bone grafting, the ABG, the result is good, that means you can see a nice bony bridge formation with cortication after the iliac bone has been harvested, then I'll say yes, go ahead and do the transplantation. But we know a lot of our patients, especially if you analyze the radiographs, that despite a very good attempt at the bone grafting, you may not have the most perfect ABG result. So in these patients with quite a big hole still, even after the bone grafting is done, you can just ask yourself a simple question. You can just ask yourself, is there enough bone so that I can move the teeth into the space, or will the tooth just tip into the bone? If you feel that the tooth can really move into the space of the cleft, then I'd be very happy to try an auto-transplantation into the lateral incisor space. But if after the bone grafting, you go, not much bone after the APG, then I'll say, let's not try the transplantation for better success. That's my opinion.
Thank you very much.
You're welcome. Okay, Per, I think you are muted, so.
Thank you. In this one, we will go for the Q&A session. And the first question is from Dr. Dong Chu Min. The doctor just said, like, hi, Dr. Koo, did you experience any bone resorption between the two transplant teeth in the upper anterior region? What is the diameters of the soft wire used for splinting after auto-transplantation? And if there is no 3D printing, can we measure the size of the extraction socket through CBCT?
Yes, so I think this is all very important, especially from the planning, because we know that for any orthodontic treatment, it's not the actual treatment, but it's more of the diagnosis and the planning. So starting with a good CBCT, it can be a regular CBCT. It does not have to be a very high resolution or small FOV in order to do your measurements, but you can do your measurements, the length, the height of the root, and also the socket width. That's how we started as well. We didn't go straight to the 3D printing. We started with measuring on the CBCT. And then when you see in real life, you say, oh, okay, it really matches, so that works. But what we find also is that when you're trying this 3D transplantation technique, I feel that we always like to, we should create a bit more space pre-transplant. So if you're putting a transplant into a socket, like our second case, I know that the tooth did fit in the end, but it's always better to do some expansion first. You can do some RME to open the spaces, open coil to open the spaces before actually placing the tooth in, because we like to put it in plus about 1 millimeter mesendically. I think your other question about the bone situation in the patient, we were following the patient up, and actually the bone is looking good. I have yet to take a CBCT, and I think when we take a CBCT at the next visit, we can check whether there's actual bony regeneration on the labial cortical portion. So that'll be quite exciting to see. And you had one more question about the wire dimension.
Yes, the wire.
I'm not the expert. I think I just spoke to my surgeon a few days ago on this, but his answer was we just use the braided wire, the twist wire inside the surgery. And I'm sorry, it's a bit embarrassing. I don't know the dimensions of orthodontist, but it's flexible and you can use the braided or the twist wire.
Thank you. And the next question from Dr. Wendy. The doctor would like to ask, in the case when there is no buccal cortical plate in the recipient site, do you put the bone graft at the buccal site or not?
In our center, we don't place any bone grafting. So I believe again that if you choose developing premolar that is more unerupted, when the tooth grows down, similar to your ABG in your cleft patients, we time it well so when it erupts, it can bring some bone as well. And there's evidence from other papers that this is possible. And your other question, sorry, can you repeat that again?
The question, right? Like, do you put the bone graft at the buccal site or not? If you don't consider maybe we can pass this question.
No. So yeah, we don't put the bone grafting there. Although if you look at Andreessen's paper from the 1990s, his 370 premolars, he did half of them, I think, without the bone graft, and he did bone grafting for the rest of them as well. So do look at that paper, but we don't do bone grafting here.
And in just like in the situation, like because of the roots of the premolar might be bigger than the incisor, and you have to remove some bone, maybe on the buccal plate. It will be have like deep pocket afterwards, but in your experience, when you do the auto-transplantation.
Actually, no, we don't have any bony issues and perio pockets, but if you're trying to do two transplantation of two transplanted teeth into the two central incisors, when you do the space closure, you start closing the spaces, the incisor papilla will sometimes get squished up, and it looks a bit funny and ugly. So no problems with the perio pocket, but you get some gum being pushed together. So you may need to consider a bit of gingivectomy. But it's a good question.
And the next question from Dr. Panat. He would like to ask, is this applicable for Caucasian? Like this application is applicable for the Caucasian, and is this a viable option to transplant into the bone graft, alveolar cleft, especially for patients with congenital missing teeth?
Yeah, so I think this is quite a similar question to what Dr. Low asked earlier, and it is something I think about all the time because I work in the cleft center, and we don't want to just do it for our normal patients. It's the cleft patients who need most of the help. So in order to transplant the teeth, you need good bone first. So the first question is really if we have good bone. If yes, then I believe that the transplantation will be a success, regardless of whether you put it in the maxilla, mandible, bone graft site. If there's bone, it will work. But if there's no bone, then let's try not to be too advanced, because always start the cases with a simple one. Don't do the difficult ones first. That's my advice.
Okay, thank you. And the next question from Dr. Yimmi popped. In some cases, the doctor flipped the premolar 90 degrees during the transplantation to the upper incisor area. And is there any difference between the flipping, the transplant premolar, and no flipping? Like when you twist in some cases that you show us today.
Yeah, so I think similarly, we also touched a bit on this earlier. The actual prosthodontic and final result, we feel that putting the premolar in straight on is easier to restore. Also, you have to discuss with your surgeon, because if we look on the internet, we find new techniques, we say, okay, let's try this 90-degree method because in theory it'll look better. But also if you turn the tooth 90 degrees and the root is a bit more wider, then naturally we have to start expanding the socket using the implant drill, and then we're back to square one, because we are taking away the precious PDL cells that we want to retain in order to maintain a good successful healing of the tooth. So I would rather not. And most prosthodontists are able to build up the tooth nicely, even if you put it straight on instead of 90 degrees.
Thank you. And the next question is from Dr. Alex Hong. He would like to ask, wondering what should do with the gap at the donor side once the tooth has been moved. What usually happens to the space once the tooth is moved?
Yeah, okay. And I think this is it's a question that all orthodontists can answer. So once you remove a tooth, naturally you think about why you're removing the tooth. If you're taking it out for orthodontic reasons, it has to fit your overall plan. So most of the patients, when they do extractions, they need 4 extractions, so it fits nicely. But there are a few patients where we actually don't need to take the tooth out. There's no indication for crowding or protrusion, but because we want to use the transplantation, we remove the tooth, and then we have to plan using TADS or special mechanics in order to mesialize all the posterior teeth to close up the space. But in general, it makes more sense and it's simpler to take out teeth that you already don't need for the braces rather than take it out and then close it up with the TAD. It's a bit more complicated, but still doable.
And the next question is from Dr. Raidmead. Is like, we want to know about the diameters of the twist wire. And the other part, the doctor would like to know, like, do you do the customized DIY product, or you just use the twist wire that the hospital has?
Yeah, this one, my surgeon is like scolding me already because I don't have the answer for the diameter of the wire.
Okay.
Yeah, because honestly, when they do the surgery, I'm not inside the surgery. They are putting the wires in, and the splint removal is also done by the pediatric dentist in our center. So we're quite spoiled here. I only take over when the patient's ready to start treatment.
And the next question is from Dr. Ploy. She had many questions. The first one, how long did you leave the flexible wire splint? The second question, do you want me to ask you one by one or all questions?
Okay, so yeah, I'm sorry, I've got short-term memory now, but I'll try. So for the wire splint, it's recommended 2 weeks is enough. Some people even do 3 weeks, but definitely not more than that. And once you remove the splint at 2 weeks, you actually notice that the tooth may be still slightly mobile, but it's safe enough to leave alone, provided there's no heavy occlusion on the teeth. So that's very important because there's no point taking out the splint only for it to bang on the bottom teeth. Then you have more chance of damage and poor healing.
Okay,
so
and
2 weeks, yeah.
Thank you. And the second question, the Dr. Ploy would like to ask if the patient is already in orthodontic treatment, such as implant auto-transplantation for hypodontia cases. Would you recommend bonding the bracket and placing the passive wire rather than placing a wire split?
So bonding a bracket and passive wire.
Yeah.
I think it really depends on what dimension you're using, because we know from research that actually the best way is to put a suture splint. So sutures, I'm not sure what the dimensions are, but it's so soft and so flexible that it allows natural movement. So we are being a bit of a cowboy by putting a wire because it's not sutures. And when you're doing a passive wire and a bracket, you have to be quite careful because any additional movement or improper bracket positioning, you may introduce a unwanted movement, which is definitely too early for the patients at the 2 week mark. So I'll prefer to keep things simple. Like if you feel that you need to have things done first, then I suggest you can even start on the lower braces first to close the spaces. You can close the space from the auto-transplant extracted site. And then at the 6-month mark, then you can start doing the upper incisors. It's safer that way.
Thank you. And the last question is from Leo, my friend, a resident from Lincoln branch. He would like to ask, he was curious about how to deal with the soft tissue in anterior aesthetic area. For example, zenith height and symmetry. Yeah.
Okay, great. I mean, this is a great question. And I think it all boils down to your what you feel is an aesthetic smile. What I think is perfect may not be what you think is nice. But when you start with the first, when you start with the patient, you have to really look at what is good and where you want the gingival margins to be. So, David Sava has talked about the aesthetics, the macro, mini, and micro aesthetics. So that's a good place to start. And if you are transplanting a tooth, which needs the gingival height to be lower, then naturally you also choose a premolar with a similar position. And what I mean here is that if you take out a tooth when the premolar is just at the gingival margin, naturally you should put the same tooth into the new location at the same height. You don't put it higher or lower. Okay, so if you take out the tooth and the tooth is just below the occlusal plane, when you move it on top, you put it at the same level, not higher or lower. And then from there, when the root develops, you can plan, intrude the tooth, extrude it as your normal finishing. So it's quite easy, but that's the biggest tip I can give you when you're doing the auto-transplantation surgery.
Thank you. And we have another question from Dr. EF. Doctor would like to ask, do you do occlusal adjustment together with the composite build-up after the splint removal to avoid traumatic occlusion?
Right. Hi, Ethan, and thanks for coming into the lecture. So the composite build-up, we normally do about 1 month after the transplant surgery. We try to avoid any high speed burr touching the tooth because it can generate some heat and the tooth may not like it for the pulpal healing. The occlusal adjustment is actually something we do much later on. So if we do the composite build-up at 1 month, the adjustment comes much later on. So we try our best to put the tooth out of occlusion so we can avoid this problem. I know in some cases where it's class 3 or you have a anterior crossbite is a bit difficult with a few of these cases. So in those cases, if you have no choice, you may need to put GIC bite turbos at the posterior teeth, or if there's really no choice, you may just do a little bit of occlusal grinding, but we try to delay as much as possible.
Thank you. Thank you very much for answer all the questions.
Thank you. I try my best.
Okay, thank you, Prayer. Yeah, thank you, Professor Gu. Actually, I have to show and present my apology for not as admin tonight. It's our first time in ICC to have a cyber attacks. In a row, we have 7. I quickly to search about a cyber attack last year in Italian Senate online meeting. It was the Zoom form attack as well. So I hope this is because ICC is so famous. So I'm not sure. But I'm seriously, as be admin, I really pay my utmost apology for presenter, Professor Ko. And in the future, I will pay more the cybersecurity to control the process. By the way, I really sincerely to share and present our gratitude. As a plastic surgeon, I know this is a very different field for us. However, Prayers, she did his very great contribution and to invite lots of our very fantastic leadership in the orthodontics in all the Asian countries. Professor Nita, Professor Ko, and Professor Liao as well. And so it's really a very excellent and very comprehensive lecture as well. Thank you again, Professor Ko. Yeah. Of course, finally, I have to announce our coming webinar in the coming Sunday as well. That will be presented by a Korean plastic surgeon, Professor Ho. Professor Ho is Asan Medical Center, and his presentation topic is the curve chiroplasty in unilateral cleft ligament patients. And now this, I would like to invite all our audience in ICC. We can have a good opportunity to a group photo with Professor Ku as well. So, my dear friend, please show your beautiful smile with us, please. Yeah, thank you. Please come in, please come in. Yeah, definitely I will edit the whole video before the uploadings. Yeah, please come again and please show me the beautiful smile and I will count to 3. Okay. 1, 2, cheese. Thank you very much. And I will turn to the next page again. And 1, 2, cheese. Okay, thank you. Thank you all of my teachers and all the audience tonight. And I hope all of you have a good day and have a good one. See you next coming Monday. Thank you very much. Bye-bye.
Thank you all for the
Thank you.
invitation. Thank you very much.
Thank you, Professor Crow.
So much.
Thank you, Dr. Cole. Thank you, Dr. Chia, and thank you, Dr. Liao, and also Dr. Ku, and also
Thank
Dr.
you.
Cho as well.
Thank you,
Bye.
Freya. Thank you,
Great, Freya.
Professor
Thanks for the
Nita.
invitation.
Thank
you,
you.
Professor Liao. Thank you, Professor Cole. Thank you, Professor Handa. Bye-bye.
Bye.
Bye.
Bye. Good night.
Good night.
Dr. Ku, don't you think like if we have a password, it will be better?
You say,
I'm curious about the Dr. Tommy session because he had more participants, right?
actually today we have more participants, and I checked with the Tommy. The IMC has been attacked once before, but not like today. So of course they have a special the password to enter into their webinar. So I probably to maybe in the future the password is definitely necessary for entering our webinar too. Yeah, I think so. Otherwise, and that's very crazy. The file ID
I
coming
know.
again.
Yeah.
You know,
It's totally bad.
it's
It's
totally bad.
terrible. Yeah, yeah.
Yeah. No worry. I will talk and discuss with Junior later. Yeah. Okay.
Thank you.
Okay. Thank you,
so
Priya.
much. Yeah, because I know every time you have to allow the audience to come in,
Yes.
but
Yeah.
I'm not sure. Yeah, but because I know it's hard to know who is the real
You're right,
attendee
because
or-
sometimes they will not to show their whole names, the first name and the last name, so not really to know who will come. Yeah. No, never mind. Have a good day. Thank you, Priya, for all of your support
Yeah, yeah.
and for these very great sessions.
Yeah, thank you. Thank you. Have a good night.
Okay,
Bye-bye.
have a good one. Bye-bye.